All right, good morning, everyone. Welcome to this week's Department of Medicine Grand Rounds. I'm Dana Bowen, one of the chief residents. Before we get started, just a few housekeeping tips. Please make sure your video is off and your mics are muted during the presentation. Also, we ask that you hold your questions and comments to the end, at which point you may unmute yourselves or use the chat box to ask questions. Lastly, the CME information will be displayed during the presentation. Today, our speaker is Dr. Etra, joining us from the Tisch Cancer Institute at Mount Sinai Hospital to give a talk on acute graft versus host disease. Dr. Etra is assistant professor in the Department of Medicine's Division of Hematology and Medical Oncology at the Tisch Cancer Institute. He earned his medical degree from Albert Einstein College of Medicine and went on to complete residency and Hemonc fellowship at Mount Sinai in New York. Dr. Etra's research interests are in acute graft versus host disease after stem cell transplant, for which he is lead investigator of several studies, including a phase 3 clinical trial. Dr. Etra has published many peer-reviewed articles and book chapters, including in the Journal of Transplantation and Cellular Therapy. We thank you and we welcome you, Dr. Etra, for joining us today to give this presentation.
Thank you so very much for the invitation to speak to you today. First, can you hear me before I move on?
Yes.
Okay, terrific. So I've entitled today's lecture, Acute Graft versus Host Disease. As you had said, I'm an assistant professor at Mount Sinai in New York. And just as far as the CME information is concerned, please text this code to the phone number listed below. I'll give a few seconds to allow people to do so. Here are my disclosures. Advisory board for chronic graft versus host disease medication. We will not be discussing it today. And some learning objectives for today. First, I'll provide a basic overview of bone marrow transplantation. Next, we'll discuss the pathogenesis of acute graft versus host disease. We will talk about the treatment of acute graft versus host disease as well as the acute graft versus host disease prognostication and the challenges in doing so. We will conclude with the potential role of serum biomarkers to revolutionize graft versus host disease therapy, specifically acute graft versus host disease. We will not talk about prophylaxis today. That's an entirely different subject, and perhaps another time. So first, bone marrow transplantation generally falls into two categories. An autologous transplant employs high doses of chemotherapy, so much so that patients would often not be able to reconstitute their own bone marrow if left alone after that high-dose chemotherapy, followed by rescue with their own stem cells. This has its advantages and its disadvantages. Compared to an allogeneic transplant, the risk of relapse may well be higher. However, the transplant-related mortality tends to be lower, less complications. An allogeneic transplant employs high doses of chemotherapy, with or without radiation, followed by rescue with a matched donor stem cells. For the eagle eye amongst you, obviously not all transplants are HLA matched. Some could be mismatched. Cord blood transplants have a different matching scheme. Haplotransplants are half matched, but the general idea is rescue from somebody else's stem cells. This type of transplant enables the patient to enjoy a graft versus leukemia effect, an immunologic anti-cancer effect, and in doing so decrease the risk of relapse. However, this comes at the risk of transplant-related mortality, whether infectious, whether graft versus host disease. This is certainly something that needs to be considered in employing these treatment regimens. Generally, when it comes to why people undergo transplant in the year 2022, this is a slide that's taken from the Center for International Blood and Marrow Transplant Research, known as the CIBMTR, the clearinghouse for transplant data world over. And the most common reason why somebody would undergo an autologous transplant would be myeloma or non-Hodgkin's lymphoma. At this point, however, we're going to focus on allogeneic transplants, and the leading indications are acute leukemias and myeloid diseases. After transplant, unfortunately, there's a pretty significant risk of mortality, not just morbidity. In the first 100 days, that risk is driven primarily by graft versus host disease. Close second would be infection. And I say close second, even though it's 37% versus 19%. Sorry about that. Yeah, 37% versus 19%, because in many cases, treatment for graft versus host disease can actually predispose people to comorbid infections. So often people have both problems. and relapse is also a significant cause of death after transplant in the first 100 days. After the first 100 days, relapse of the primary disease for which the person was transplanted becomes the leading driver of mortality, with graft versus host disease coming in second. In other words, relapse is a substantial cause of mortality, that is true, but graft versus host disease and infection are the primary causes of non-relapse mortality. And thus, it is important for us to optimize our strategies to both prevent as well as treat graft versus host disease. Graft versus host disease. Graft versus host disease is an immune-mediated inflammatory disease process that results in tissue damage with clinical manifestations of rash, hyperbilirubinemia, and or GI symptoms. And we'll talk about what some of these symptoms can be, but we're talking about things that run the gamut from anorexia to frank ileus and massive hematochezia, severe pain. This is the destructive counterpart to the graft versus leukemia effect of allogeneic transplant. The pathogenesis of graft versus host disease can be described in a 3-step model, and there are additional nuances that can be added, but what happens at graft versus host disease is that over the course of the conditioning process, patients do experience some degree of tissue damage, and host antigen presenting cells are activated. These antigen presenting cells in turn activate the donor T cell compartment, and that in turn directly causes inflammatory effector cell mediated damage, as well as cytokine dysregulation of both the donor and recipient immunologic milieus, resulting in further tissue damage and a perpetuating process that just continues to go and cause potentially significant morbidity and mortality for our patients. This is a really terrible example of skin graft versus host disease, which can literally range from a mild maculopapular rash over a small portion of a person's body to literally, just generalized erythroderma, bullae, and the phenotype of somebody suffering from severe burns. From the standpoint of histology, the histologic findings of graft versus host disease in the skin really is characterized by apoptosis of the keratinocytes. Interestingly, there's minimal lymphocytic infiltration. When it comes to the GI tract, the findings are characterized again by apoptosis of cells in the crypts, and in the context of the intestine, you can actually see crypt drop out altogether. So on the left, this is a normal crypt. On the right, there aren't even any crypts to look at. And in the liver here, lymphocytic infiltrate and injury is actually visible. Hemosiderin is deposited. In terms of grading and staging graft versus host disease, to actually clinically characterize it in hopefully a reproducible fashion and to help hopefully prognosticate, several systems have been developed over the years. The one which has become the gold standard is the so-called MAGIC staging. And this employs a 0 to 4 stage, with 0 being the least severe. In the context of all but the GI tract, it actually would constitute non-GVHD at all, and ranging up to stage 4, which would be the worst of the worst, the people who are unfortunately suffering the most morbidity, and in theory, those who might suffer the worst mortality, but we'll get to that in a little bit. As far as the skin, it's literally graded, or staged rather, in the same way that you would stage a burn victim, with the rule of 9s and calculating the body surface area of the affected portion of the patient. So stage 1 GVHD patient of the skin would have less than 25% body surface area involvement. A stage 2 GVHD patient of the skin would be 25 to 50% of the body surface area. Stage 3, more than 50% of the body surface area. And stage 4 would be generalized erythroderma, so over 50% of the body surface area, accompanied by bullae and or desquamation. Liver GVHD is characterized, at least in the acute setting, by the degree of hyperbilirubinemia, with mild hyperbilirubinemia reflected in a lower stage, and more severe hyperbilirubinemia reflected in increasingly worse stages. Upper GI GVHD is graded, or rather staged, in a binary fashion. It is either there or it is not. And the characteristics of upper GI GVHD include persistent nausea, vomiting, and anorexia. Lower GI GVHD, up to the point of being a stage 4, is characterized by the volume of liquid stool output. We're talking about liquidy stool, not form stool, like absolute liquid. And stage 4 GVHD is characterized by severe abdominal pain, ileus, and or hematochezia. the mortality in GVHD is driven primarily by lower GI GVHD, less so with skin or upper GI or liver. Liver GVHD isn't even all that common at this point in 2022. In terms of amalgamating the different organ stages into an individual grade, so in other words, let's say you have a patient who's got stage 1 skin and stage 3 lower GI GVHD, how would you capture that? And that would be done using grading. And the grade is comprised of the different organ systems in the following scheme. So patients who have isolated skin GVHD of the low stages would be a grade 1. People who have potentially more extensive skin, plus or minus liver or GI tract, would have 2. And ultimately, people who have the most severe stage 4 involvement of any organ would be characterized as grade 4 GVHD. Treatment. So graft versus host disease treatment for mild skin GVHD, so a localized, relatively mild, right, rash in many cases, or an isolated upper GI GVHD, again, anorexia, nausea, vomiting. These folks would be treated with topical steroids. So you may ask, how would you treat a GI tract with topical steroids? That would be using something like budesonide, so theoretically a non-absorbable steroid preparation. Systemic steroids are the mainstay of GVHD treatment for folks who are suffering from grade 2 or above, and this has been the case for literally decades. Patients who do not respond to systemic steroids unfortunately remain a therapeutic challenge. So the path for figuring out how much steroid to use may seem like a simple one, but one that actually, has been studied over time. And, one question which we're not going to touch upon today because there aren't clear answers is how best to actually taper the patients once you start them on steroids. There really isn't a clearly defined evidence-based answer, and that's something which our research group does hope to contribute to. But in the past, people used extremely high doses of steroids. So, for example, this was a trial that compared 10 milligrams per kilogram per day of methylprednisolone versus 2 milligrams per kilogram of methylprednisolone per day for the treatment of GVHD, acute GVHD. So this was a study where they were allowed to have crossover. So if a patient didn't respond at day 5, they could be switched from the 2 milligram to the 10 milligram arm. And there were, in fact, 26 patients in this 95-patient study who did crossover. Nonetheless, they did not see any difference in the rates of non-relapse mortality, which is the same as transplant-related mortality. They're synonymous, as well as survival. There was no difference in either arm, in either transplant-related mortality or survival. And so with this, 2 milligrams per kilogram per day became the standard of care for patients who required systemic steroids for the treatment of graft versus host disease. And ultimately, the question still becomes, can you spare patients the morbidity of steroid therapy? Even 2 milligrams per kilogram is an awful lot if you think about it. This isn't a case where you're treating somebody for 5 days and then you stop. Often these patients are treated for weeks and weeks. And so ultimately they run into all sorts of problems, whether it's infections, delayed immune reconstitution, osteoporosis, hyperglycemia, you name it, they get it. And so the question is, can you spare patients the morbidity of high doses of steroids? So at this point, we've gotten from 10 to 2. The question now becomes, can you do better? Can you use 1 milligram instead of 2 milligrams? Now, I recognize this is not a direct comparison in that this was the use of prednisone as opposed to the last study, which was methylprednisolone. They're not bioequivalent exactly. It's 80% one versus the other. But in any case, in this study, the authors did a retrospective study of 733 patients transplanted between 2000 and 2005 who received prednisone. So this is based on real world. This is what people did, right? Not a randomized trial. And in this case, the patients received 1 milligram per kilogram per day of prednisone. And that was one group. And then they looked at the patients who received 2 milligrams per kilogram per day of prednisone. They found no significant difference in the rates of non-relapse mortality. I realize there's a split in the curves, but this was not significant, right? 0.73 was the p-value. And likewise, the survival curves, again, were not significantly different between the so-called high dose, the 2 milligrams per kilogram, and the low dose, 1 milligram per kilogram arms. The problem from this study, however, was that not enough grade 3 or 4 GVHD patients were included for the authors to make any conclusions about this high-risk group of patients. And that makes sense if you think about it, right? Because ultimately this was a retrospective study. The patients who had really severe GVHD were treated relatively aggressively. And so relatively few patients in this retrospective study were treated with low doses of steroids. So it makes sense that they wouldn't have as many to look at. In any case, you can, this study shows as well that at least in a subset of population, you can use less steroids and in doing so decrease the morbidity without compromising GVHD outcomes. What was interesting in this study also was that there was a significantly lower cumulative dose of steroids in the first 100 days after treatment was started. So instead of 87 milligrams per kilogram, patients had 44 milligrams per kilogram of prednisone use, which represented a 48% reduction. So, this was, certainly something that required further assessment. And so the same authors, this was a paper published in Blood in 2009, did a phase 3 randomized study. And what they did is they split the patients that were enrolling into two groups, generally speaking. One group was a group of patients who had, low risk GVHD, relatively isolated, low grade GVHD, and they randomized those patients to 1 milligram per kilogram per day of prednisone versus 0.5 milligrams per kilogram per day of prednisone. And to be more precise, these were the patients who had upper GI GVHD or a rash with less than 50% body surface area or stool volume of less than a liter per day, no liver dysfunction. This was the group of patients who were randomized within the so-called low dose arm, right? The 1 milligram versus the 0.5 milligram. And there were 102 such patients. Then they had an additional group for patients who had more than 50% body surface area, more than a liter of diarrhea or liver dysfunction. Those were the patients that were randomized to 2 milligrams per kilogram per day versus 1 milligram per kilogram per day. And their primary endpoint was a greater than or equal to 33% reduction in the cumulative prednisone dose at day 42. And so this was very interesting for a variety of reasons. First of all, there was no difference in non-relapse mortality in either group, and there was no difference in survival in either group. However, whereas this group of patients, the 1 milligram versus 0.5 milligrams, did not have any difference in steroid refractory GVHD. To be more precise, steroid refractory GVHD refers to those patients who do not respond to steroids. They did not see any increase in the risk of this. Likewise, there's no risk. There was no increase in the rate of relapse, no increase in the rate of chronic graft versus host disease. So that was actually very promising. And in doing so, you can argue that they've established a standard of care of even lower doses for the grade 1-2 GVHD patients. However, in this group, the higher risk group, the 2 milligram versus the 1 milligram group, in that case, there was an increased need for starting second line therapy, which is to say an increased risk of steroid refractory GVHD. And in doing so, they've effectively said that maybe we shouldn't be dropping our steroid dose from the 2 milligrams per kilogram in the high-risk patients. What was also interesting about this is that the cumulative steroid doses were essentially the same. So in other words, you may have started off lower. However, patients were also tapered over a longer period of time. So, you could argue that the benefit of the decreased steroid dose was in some respect ameliorated by the fact that over time the patients ended up receiving the same amount anyway. So there's still clearly a lot of work to be done, even in the most basic of questions, how to dose steroids in this population. But what I'll talk about next is a pathway which is especially relevant, that is super relevant, in the graft versus host disease space, because it's one which has given us the first approved treatment for steroid refractory GVHD ever, actually. So the Jackstat pathway generally. So in mammals, homodimers and or heterodimers of 4 JAKs selectively bind 4 downstream stats, which in turn, affect cell signaling. Dimer configuration confers receptor selectivity, and over 20 compounds use this system, and that's certainly very notable. In the GVHD space, there are several cytokines that are involved in the pathogenesis of graft versus host disease. Some examples include, this is not an exclusive list, but IL-2 and IL-6, and both of these bind, and facilitate cell signaling via the Jackstat pathway. And what's interesting in both of these cases is that JAK1 is a common thread in these two particular cytokines in their signaling. And so the theory is that if you block, the JAK1 anyway, that you'll in effect decrease the severity of graft versus host disease if you're going to look at it in the prophylactic setting, and that you can potentially use it in the treatment setting as well. The problem is that when you block in a non-selective fashion, say let's say you block JAK1 and JAK2, then you also hit other things and end up with other toxicity. So for example, ruxolitinib, which we're going to talk about, in a couple of slides, which is sort of famous in the myelofibrosis space, but is now, certainly taken root in the transplantation setting as well. It's a JAK1 and a JAK2 blocker. And so if you give that to a patient, well, if you're knocking out JAK2 and that is involved in the binding of erythropoietin, thrombopoietin, and GM-CSF, you'd expect that cytopenias would be a toxicity that you would need to contend with, and indeed, this is the case. So going back to that original pathogenesis scheme, this has actually been done in a series of laboratory papers where folks have shown that if you give a JAK inhibitor, you can decrease antigen-presenting cell activation and migration. You can decrease CD4 and CD8 cell activation. And this makes ruxolitinib or other sorts of JAK inhibitors potentially attractive candidates as prophylactics, as preventative agents for graft versus host disease. By the same token, JAK inhibition also is thought to decrease T-cell migration and cytotoxicity, decrease neutrophil migration and their antigen-presenting cell activity, as well as direct neutrophil-mediated tissue damage. And in doing so, this makes JAK inhibitors a potentially attractive treatment for graft versus host disease, and indeed, this has been done. So in current clinical practice, ruxolitinib, Jakafi, is the only FDA-approved treatment for steroid refractory GVHD as of now. And this came about as a consequence of two clinical trials. One was the REACH1 trial, which was a single arm. It was ruxolitinib 5 milligrams twice a day, 71 patients, and they looked at response rate, NRM, survival, AEs, all the usual things. And day 28 overall response rate was 55%. For some historical context, steroid refractory GVHD is often very difficult to treat, has a high incidence of morbidity and mortality, and this was thought to already be pretty exciting. The 6-month non-relapse mortality was 44%, which may not sound very good. And again, to be clear, non-relapse mortality means death due to any cause apart from relapse of the primary disease. Overall survival was median of 8 months. And at 6 months, 51% of patients were still alive. And as far as hematologic adverse events, you'll note that that theoretical concern about blocking JAK2 as well as JAK1 does bear out in actual clinical practice, with 42% of patients experiencing thrombocytopenia, 28% anemia, and 21% neutropenia. Nonetheless, this study gave rise to the REACH2 study, which was a ruxolitinib 10 milligram dosing strategy, and that was compared against the best available therapy, investigator's choice, if you will. This was a randomized phase 3 study involving 309 patients. The overall response rate at day 28 was significantly improved with the use of ruxolitinib, 62% versus 39%, in fact. At 6 months, the NRM was 36% for ruxolitinib, 43% with the alternative therapy. But ultimately, by the time you got out to 18 months, there was not even a numerical difference to speak of in non-relapse mortality, let alone a statistically significant one. At the end of the study, they had not identified a significant difference in median overall survival either. So that is not as good. When it comes to the hematologic adverse events, again, you'll note that it's a similar profile to the REACH1 study, again, hematologic toxicity being non-trivial. And I should add that there is the confounder that people who suffer from really severe graft versus host disease often do have marrow suppression, much as you potentially see in a septic patient where in the context of a cytokine storm, the marrow is suppressed. You do see this to some extent, in the graft versus host disease setting as well. But, this was thought to be due largely to the drug itself. So going back for a second, if steroid refractory GVHD is such a big clinical problem and steroids are imperfect, why not do something else? Why not add to it? So take another promising agent, add it to steroids, and see whether that can improve upon your outcomes, both in terms of direct, without needing a secondary therapy, but also minimize the risk of steroid refractory GVHD. And over time, many trials have been conducted, anti-T-cell receptors, anti-CD3 antibodies, adding MMF, pentostatin, etanercept, mesenchymal stem cells, among others. And unfortunately, while the response rates look super good in phase 2 studies, often single center or a couple of centers. When you roll them out to phase 3 multi-center trials, they fall flat on their face. They don't end up working. And the question is, why is it that all these promising medications fail? After a while, you have so many good phase 2 trials. Why aren't you getting to good phase 3 trials? And so part of the problem is that clinical data are highly variable, difficult to collect, and practices are not standardized. And clinical response, frankly, is an imperfect predictor of mortality, right? So day 28 overall response rate is the surrogate endpoint that is often used in graft versus host disease clinical trials. Maybe that isn't the best idea. In addition, multi-center data up front, in theory, are crucial for construction of accurate prediction models. I should just go back to the first point for a second when I say clinical data are variable and difficult to collect. If anybody's taking care of a transplant patient before, diarrhea is a common side effect of chemotherapy, of radiation, of infections like C. diff or CMV colitis. Actually making a diagnosis that is the correct diagnosis is not always straightforward. By the same token, rashes are common in the transplant setting. Patients are often getting many medications, many of them new to the patient. Drug rashes are common. Infectious rashes are common. It's not always so straightforward to make the diagnosis accurately. And when you're trying to run a clinical trial, obviously making the correct diagnosis is absolutely critical to make sure that your inclusion criteria are met. So there's some that already adds some complication. In any case, our research group at Mount Sinai, the Mount Sinai Acute Graft versus Host Disease International Consortium, which is led by Dr. John Levine and Dr. Jamie Ferrara. This was founded to gather high-quality clinical data and correlative samples, not just here at Mount Sinai, but in centers world over. And this employs a standard graft versus host disease grading and staging system. It's not just the table, which I showed you earlier, that describes how you stage and how you grade, but we also have fairly extensive documentation and manuals and procedures around how you would actually make an accurate diagnosis and accurately stage these patients. The data managers are trained in a uniform manner, and it provides an unparalleled research and clinical trial platform in this space. And at this point, the MAGIC Consortium, as you can see, has grown to be rather large, involving many centers both in North America, not just the United States, but also in Canada, in Europe, and in Asia as well. So, back to the point that, clinical severity at diagnosis, may not be the best way to even predict which patients will do well and which ones won't. This goes to the prognostication question. So let's say you have a patient who starts off with grade 3-4 GVHD, right? We talked about that earlier on. These are the patients who have severe liver dysfunction, severe GI symptoms. You would think that these patients would respond less to treatment than the patients who have mild skin GVHD, less than 25% body surface area diagnosis. And in fact, that is not the case. It's numerically smaller, but it's not a significant difference. And indeed, even when you look at the non-relapse mortality of these patients, the patients who originally had severe graft versus host disease at diagnosis, again, from a statistical standpoint, don't do any better than or any worse, I should say, than the patients who had grade 1 GVHD at diagnosis when you look at large data sets. And so this calls into the entire question about, if you have a patient with severe GVHD at diagnosis, are they necessarily the person who needs intensified therapy? Maybe, but maybe not. And what makes things even more complicated is that if you're going to use clinical staging to try to figure out how a patient will do and to try to use them in inclusion criteria in studies, so the problem is that maximum grade does correlate with outcomes. This was a paper published in 2013. People who have grade 4 GVHD at its worst, not at diagnosis necessarily, but at any time, these patients will do worse. They'll have the highest non-relapse mortality as compared to the patients who have the max grade of, say, grade 1 acute graft versus host disease. And this poses major challenges in clinical trial development, right? You don't know how badly somebody's going to do in the future. I wish we would, right? That way we would know what to predict, how to prognosticate, but we don't know how badly somebody's going to do at diagnosis. And so you can't use these data for study inclusion criteria or to empirically intensify therapy, which, gave rise to a clinical risk prediction model, right? Called the Minnesota risk criteria. And this was based on a study. It was an analysis of 1,723 patients out of Minnesota. And this was a classification scheme for identifying what they called a standard risk patient, a low risk patient, same thing, or a high risk patient. So a standard risk patient was defined in one of two ways. In an isolated organ system. This patient would have, theoretically, a standard risk patient would have isolated skin stage 1 through 3 GVHD or isolated GI stage 1 through 2 GVHD. If you're going to look at two organ systems, so a patient has two organs involved at diagnosis, they either have stage 1 through 3 skin plus GI1 or stage 1 through 3 skin, and interestingly, liver stage 1 through 4, which always was a bit of a surprise to me, but even the high-risk liver patients, or rather the high-grade liver patients, with skin still seem to do better than you'd expect them to. In any case, this system does create a stratification that is potentially clinically useful, whereby the standard risk patients have a 22% chance of non-relapse mortality at 6 months, whereas the high-risk patients have a 44% chance of non-relapse mortality at 6 months. So, this does potentially provide a useful tool for prognostication before you hit that point of maximum grade GVHD. Other question, though, is can you use a system? Can you devise a system which uses a blood test to identify which patients are going to do well and which ones will not? And in doing so, allow you to, in an unbiased fashion, create inclusion criteria in clinical trials and hopefully figure out which patients, will do well. In theory, this also works the other way too. If you know somebody's going to do well, perhaps you can use less intensive therapies. You can de-intensify their therapy. You can de-intensify the morbidity associated with that therapy. And so the use of biomarkers has become, very much an active topic of conversation and research in the GVHD space. And so here I've listed several of the biomarkers which have perhaps among the strongest research base at this time. There are others. So for example, ST2 is a marker of organ damage. In the context of GI GVHD, it's certainly increased. Reg3 also increased in the setting of GI damage. Amphoregulin is an endothelial marker, which has potentially shown its value. And on the systemic level, just in terms of systemic inflammatory cytokines serving as biomarkers, TNFR1, TIM3, and IL-6 also have certainly been shown in several studies to be potentially valuable. Individually, these biomarkers have been shown to help predict non-relapse mortality and survival in some cases, right? NRM is non-relapse mortality, OS is overall survival, and treatment response is listed as TR. And so, already this is getting to be interesting. And combinations of biomarkers have likewise been shown to be predictive. And so the general hypothesis that went into developing a biomarker algorithm panel that Dr. Levine published in 2015 in Lancet Hematology that has become the basis for the Mount Sinai acute graft versus host disease algorithm probability for predicting GVHD outcomes. The hypothesis was that a panel of biomarker concentrations at GVHD onset can overcome the center effect, which is to say that, again, I might define something differently than somebody at a different center, making it harder to randomize, harder to generalize data over multiple centers, and stratify patients for risk of non-relapse mortality at 6 months. In devising this initial paper, they employed a training set of 328 patients derived from Michigan and Regensburg in Germany. The inclusion criteria in the study were people who were diagnosed with grade 1 through 4 GVHD. The patients had to have a research sample that was obtained within 72 hours of onset of GVHD. And they tested every possible combination of ST2, again, a GI damage biomarker, TNFR1, a systemic biomarker, Reg3 alpha, GI biomarker, IL-2 receptor alpha, elephant, which is a skin biomarker, and they used competing risk regression to figure out which combination would be the best combination for predicting non-relapse mortality. And what they found in this study was that a combination of ST2, TNFR1, and Reg3 alpha provided the best model for predicting 6-month NRM, and it generates the probability of NRM for each patient. And in doing so, they were able to identify thresholds for defining, again, using the algorithm probabilities from biomarker concentrations. They're able to identify patients at low risk, intermediate risk, and high risk of developing 6-month NRM. And they deem these the Ann Arbor scores, with low risk being Ann Arbor 1, intermediate Ann Arbor 2, and high risk Ann Arbor 3. They then validated their findings in an independent test set, also from Michigan and Regensburg, and then validated it in a multi-center set from the BMT-CTN GVHD trials. So BMT-CTN is the clinical trials network that serves as our cooperative group in the bone marrow transplant space. And very, very, very importantly, the Ann Arbor scores were shown to predict non-relapse mortality. So in the training set, Ann Arbor 1 score is here in gray. At 6 months, the Ann Arbor score, was able to identify patients at relatively low risk of NRM, less than 10%. Ann Arbor 2 patients were at higher risks, significantly so. Ann Arbor 3 patients, even higher risk of NRM. And when they rolled this out into the test set, they were able to reproduce the findings, and likewise in the validation set. And in defining the Ann Arbor scores, they were able to identify a predictive biomarker when drawn at diagnosis, enabling people to risk stratify patients. And very interestingly, right at the beginning, I mentioned that graft versus host disease is sort of the other side of the coin to the graft versus leukemia effect. So one might have thought that a high risk Ann Arbor score, so high risk for graft versus host disease outcomes, would likewise correlate with low risk of disease relapse, or an Ann Arbor 1, right, a low risk for GVHD outcomes, for adverse GVHD outcomes would be at higher risk for relapse. That did not turn out to be the case. So in other words, the patients who are Ann Arbor 1 were not at significantly higher risk of relapse, yet were at lower risk of non-relapse mortality. Likewise, Ann Arbor scores predict treatment response. So if you sort of flip it on its head, you don't start from treatment response to figure out how people do, but rather you look at treatment, you look at Ann Arbor scores to just see whether they clinically do well. And in that case, the answer is yes. So Ann Arbor score of 1 reflects a higher rate of response at day 28, and likewise 2 and 3 increasingly worse responses at day 28. And this too replicated in both the test and validation sets. Later on, in the context of some manufacturer's changes to the analytes, a new biomarker algorithm was constructed, which did not actually require TNFR1, and likewise was able to risk stratify patients into high, medium, and low risk groups, Ann Arbor 1, 2, and 3, without the use of TNFR1, but maintaining the ST2 and Reg3. And so this biomarker tool allows us to accurately prognosticate at the time of GVHD diagnosis before the patient has clinically declared themselves as somebody who will have particularly severe disease and who won't do well. And this allows us to potentially de-escalate therapy in low-risk patients and escalate therapy in high-risk patients. So this is potentially a revolutionary tool in the treatment of a graft versus host disease patient. So, part of the question also was, though, can you actually use the biomarker algorithm at different points in the treatment course to help further guide therapy? So a frequent problem that we come across clinically is what happens if you start a patient on steroids, high doses of steroids for graft versus host disease. A day goes by, 2 days goes by, 3 days, 4 days, 5 days, and things just aren't moving. The patient's still not getting better. They're not getting worse, but they're not getting better. Do you now throw a second agent, a third agent, a fourth agent at this situation? Or do you say, okay, wait a second, let's just be patient? And so it's very easy to say, just be patient, but there's somebody who really isn't feeling well in front of you. And there's always that concern that if you don't escalate therapy, they will end up doing poorly. And so what this study showed, which was published in Blood in 2018, was that you could take the biomarker algorithm and measure it at day 7. And people who had low risk for GVHD progression, or rather for non-relapse mortality at day 7, those patients were more likely to be okay, even if you didn't escalate therapy, that their non-relapse mortality would remain low. Whereas people who are high risk for developing non-relapse mortality as defined by ST2 and Reg3, these were patients who didn't do as well, and certainly supports the idea of escalating therapy. And this translated into survival differences and also into whether they would respond to treatment by day 28. So in other words, if you had somebody who was low risk by biomarkers at day 7, those patients were at increased risk, but not as high a risk of dying. But they also were more likely to respond to treatment eventually. And this is, again, a training set validation cohort and validation cohort design. So I'm only showing the data for the validation cohorts, but the same thing was true for the training. And they did this in a second validation cohort as well and showed the same thing. And so this already just added additional clinical utility to the use of an ST2 Reg3 alpha based biomarker algorithm. Which brings me to something which is a very interesting idea, which is actually in review now. Whereas before we've shown that GI damage biomarkers ST2 and Reg3 alpha that this is a a biomarker algorithm that is able to have powerful prognostic implications at various points along the GVHD clinical continuum. So the question becomes, though, can you look at markers of systemic inflammation to likewise help prognosticate and predict, right? So figure out which patients will respond to treatment, which patients will ultimately achieve both good short-term outcomes in the form of good response to treatment at day 28, but also longer-term outcomes like non-relapse mortality and overall survival. And so in this study, we also employed a training set, so a retrospective look at patients, 352 of them drawn from 11 centers, measured several biomarkers at diagnosis, again, ST2, Reg3 alpha, TIM3, TNFR1, and IL6, and used a forward regression to figure out which patients would, which biomarker algorithms would be the best for predicting non-relapse mortality at 6 months, and then used a validation cohort to figure out whether this actually played out to actually predict 6-month NRM. And that was 378 patients drawn from 19 centers. And what we showed was that patients were able to be stratified into high and red and low blue risk groups with markers of systemic inflammation as well. So we were able to predict which patients would eventually develop grade 3-4 GVHD. We were able to predict which patients would develop steroid refractory GVHD. And likewise, we were able to, again, show that the same was true with GI damage biomarkers as well, albeit with larger deltas. So in other words, the difference between the high and low risk population was larger when you employed the GI damage biomarker algorithms. And so algorithms comprised of markers of systemic inflammation predict max grade 3-4 GVHD and the steroid refractory GVHD, as do algorithms comprised of GI GVHD biomarkers. Now, in terms of treatment response, again, both types of algorithm, those that are reflective of systemic inflammation and those that are reflective of GI damage, are able to predict response to treatment at day 28. However, this doesn't necessarily translate into longer-term outcomes when you look at markers of systemic inflammation, TNFR1 and TIM3. In this case, there was no significant difference in non-relapse mortality or survival, whereas when you add a GI damage biomarker, one of them or two of them as an ST2 or Reg3 alpha, there you also will get significant differences in non-relapse mortality and overall survival. So algorithms comprised of markers of systemic inflammation predict response to steroids. That's good. But GI tissue damage biomarkers are critical for predicting long-term outcomes. So what are the implications of the biomarkers, whether you use an ST2 Reg3 based platform, whether you use a marker of systemic inflammation, whether you use something different altogether? What are the implications of biomarkers in designing clinical trials for this unmet clinical need, right? We still are using steroids all these years later. They don't fix the problem for all patients. There's considerable morbidity, steroid refractory GVHD, even the state-of-the-art FDA-approved drug is imperfect, right? So how can we use biomarkers to improve our clinical trials and hopefully improve the outcomes for our patients? So for the low-risk patient, you want to avoid overtreatment, right? So for the patient who's got mild disease that would have done well with relatively little therapy, do they really need to be on high doses of steroids for weeks and weeks and weeks? And in doing so, subject them to all the toxicities associated with that? Well, for the low-risk patient, we've had 2 trials open within the MAGIC Consortium. One of them is itacitinib, which is a selective JAK1 inhibitor, specifically for patients who are Minnesota standard risk, so they're clinically low risk, and they also are Ann Arbor 1, so they're biomarker low risk as well. And what's nice about this trial is it's completely steroid-free. The patients are not receiving systemic steroids at all. The second study is a study which is going to look at a rapid steroid taper. So remember how I mentioned that earlier on that there really isn't a clear path toward tapering steroids. It's sort of dealer's choice, unfortunately, physician's choice. Well, here the idea is to use a rapid steroid taper in a low-risk pediatric population to hopefully minimize the exposure to systemic corticosteroids, and in doing so, minimize the morbidity associated with those drugs. For the high-risk patients, perhaps we're undertreating these patients. Maybe the reason they don't respond to steroids is because they need something more, and maybe the reason why they haven't responded to the something more in the past is because our trial designs weren't very good as a medical community. So the idea here is to identify high-risk patients and escalate their therapy in this population specifically. And so the first study looked at adding natalizumab, which blocks T-cell trafficking to the gut, in addition to steroids for the upfront treatment of high-risk GVHD, Ann Arbor 2 or 3, right? So those are the patients who by biomarkers were at increased risk for non-relapse mortality. The second study, which is ongoing in Europe, adds extracorporeal photopheresis, ECP, to steroids for upfront treatment of, again, this high-risk population, the Ann Arbor 2-3 population. And so, stay tuned for results. So as far as conclusions, graft versus host disease unfortunately remains the leading cause of non-relapse mortality after allogeneic transplant. Biomarkers provide a means of accurate prognostication. Biomarker-guided clinical trials may help address a major unmet clinical need. And I greatly appreciate everyone's time and attention. I'm certainly glad to entertain questions, but I'm just going to pull up the CM, and of course, acknowledgments to all the people in all the countries and all the centers that make work like this possible. And I'm going to just add the CME information again for everybody who still needs it. Thanks.
Dr. Etra, thanks so much for a very detailed discussion of graft versus host disease and a very interesting presentation around the complexity of surrogates in disease, and especially in complicated diseases, and trying to find those that actually can help you clinically in terms of both treatment and outcomes. So just want to encourage people and everybody, if you want to put a question either in the chat box or raise your hand. And while we're waiting for that, let me just ask you about these markers, these particular two biomarkers. Do they actually correlate with disease activity, so much so that in the individual patient, you can follow them as a response to therapy and really tell you where they are? They might start as a high risk, but perhaps, again, given the complexity, they may respond differently, and then the biomarkers themselves really are predicting where they are over time, and can they then go into a lower risk group. So do they correlate with disease activity, which is often a thing that we'd like to try and get at with some of these kind of biomarker type usage?
Yes. So that is actually something which, like you said, is absolutely a major thing which we've wanted to achieve. Ultimately, if you can take some subjectivity out of a clinical assessment, you say somebody had 3 liters of diarrhea, now they have 2.9, it's very hard for, to build clinical trials around that. And instead to say, wait a second, we know that somebody is less likely to succumb to their illness if you have a quantitative biomarker that decreases. Oh my goodness, that's a great endpoint for a clinical trial. Our group did study this and published a paper, if not mistaken, in Leukemia in 2020, which did in fact show that these biomarkers, ST2 and Reg3 alpha, can be used as a response biomarker, and that their decrease over time over the course of treatment does correlate with clinical outcomes.
I think that's tremendous. And so really it's great work, and really interesting to be able to do that in such a complex disease. While waiting for other questions that people have, please feel free to chime in. Yep.
Dr. Craw, one thing, thank you so much. I think it's really a fascinating disease, and what wasn't mentioned in your introduction is that you trained with Dr. Craw, and so I was particularly interested in getting at this topic, and when I asked him, he suggested you right away as really an expert in the field, so thank you so much. I have a couple of questions. One, what is the mechanism of steroid refractory, and is it at all related to dosing? And for people who do get tapered and then they have flares, is there any decrease in response then when they're treated?
So as far as the whether dosing correlates with steroid refractoriness, it's a bit of an unanswered question. One of the studies which I had cited earlier, for the Hematology study, did show that there was an increased risk of steroid refractory GVHD in high-risk patients who were started on lower doses of steroids, which would suggest that there is a threshold effect, that you have to get a certain amount of steroids for a particular patient to achieve an outcome. And steroid-dependent GVHD, so people who do get better, but the second you start tapering them, they end up flaring. That certainly is something which is observed clinically. As far as flares are concerned, there are people who, once you start tapering them, they do end up developing steroid refractory GVHD. The specific mechanism by which folks become steroid refractory, I don't think is actually well described.
Thank you.
Thank you.
For the sake of completeness around this, in this patient population, which are getting these bone marrow transplants, in the mechanism of how this all begins, where do the host antigen presenting cells come from? If presumably in the run-up to this, there's been eradication of really all these cells.
So at times, the host antigen presenting cells are not fully eradicated. So with a myeloablative transplant there, you're really doing your best to eradicate all hematopoietic tissue and effectively ablate the person's immune system. But for folks who are not having a myeloablative transplant, they may well have some of residual hematopoietic or immune elements that remain. So that's part of it. And then also when you take the donor cells, they may end up actually having some antigen presenting cells admixed into their stem cell pool as well, especially when you're giving bone marrow or even PBSCs. That you can run into trouble that way as well.
Oh, great, thank you. Very interesting. Other comments, questions?
Yeah, hi, Dr. Klebels. It's Dr. Krah. How are you?
Yes, Dr. Krah.
Thank you for a wonderful talk, Dr. Etra. It's great to hear and see you again. Actually, I have a question a little bit different than typical. Is that one of the things that somebody who's obviously trained in hemonc and has done some transplant and fellowship, we kind of know as a community, and you've gave a whole talk about this, about the tremendous risks involved after the transplant. Now, once the patient already has been through the ablation and getting the transplant, now has count recovery, the risk of acute graft versus host disease, in addition to the other things you mentioned, is a really big driver of mortality, NRM. How do you go about, kind of from a patient perspective, like explaining or counseling a patient when these situations are occurring about what they're going up against, or how do you bring this down, I guess, on a patient level to the patient in front of you?
That's an absolutely great question. And, I think it's also one which is individualized to the patient. Before a person even begins the transplant process, part of it is to discuss, to the extent possible, the ups and the downs that they will likely experience. There's a whole movement at this point to include another endpoint in clinical studies called the GRFS, the Griffiths endpoint, graft versus host disease-free, relapse-free survival. Because ultimately, as a patient, if somebody were to hear, I could have graft versus host disease, right? I could relapse, I could this, I could that, right? The question is, what are the odds of that happening? Right? Because if you cure the disease and yet they end up with a new horrible disease, is that really, something that somebody would want? And so, you have to do your best to pull the data as it exists right now, the emerging data, the active data, to make sure that patients are aware of what the possibilities are. Their individual risk for developing graft versus host will depend on a series of factors going into the transplant, the degree of their match, for example, the type of conditioning that they will receive, even the disease process which they have experienced, the medications they've received for it. A famous example is in the case of ATLL, if a person were to have received mogamulizumab, right? It's important, just as you tell a patient who got a medication like inotuzumab that they're at risk for VOD, increased risk for VOD, you would likewise have to adjust, your counseling of the patient depending on their particular circumstances and their particular risk. But when it comes to how you counsel a patient who already has, so in other words, they should already know before the transplant even happens that this is a potential outcome. Right? This is something that every patient who's undergoing an allogeneic transplant needs to know, that acute graft versus host disease is a possibility, chronic graft versus host disease is a possibility, and what that could look like for them. But once the patient actually gets it, part of the question becomes, how extensive is their disease up front? And if they're already starting off with, a grade 4 GVHD, that's not super ideal. But the fact that you now have the biomarker algorithm like ST2 and Reg3 alpha allows you to prognosticate. At this point, it's evidence-based, it's across multiple trials, it's commercially available, and you can draw these biomarkers at diagnosis, and you can actually, fortunately or unfortunately, quantify the degree, the risk of non-relapse mortality. And, part of it is, I think, also a shared decision-making model of some patients want the most granular of detail, other ones don't. But I think that this data should be offered to them should they wish to have it.
Thank you.
Thank you. Thank you. Dr. Schutzer? Dr. Schutzer, I see your hand. Yep.
Yeah, thank you. That was a great lecture. I want to ask you this, and this is somewhat of a spin-off of Mark's question. Even identical twins get GVH. So what is that telling us? Maybe disbalance between the different types of T cells, and is it any clues of how maybe we could do a better job, or at least you can do a better job in jumping on these patients early, or maybe even a more earlier and milder way?
So another fantastic question, one which is a real challenge to study, though. Syngeneic transplants, I didn't even mention those because they happen so vanishingly rarely. It's a population which is just so difficult to study because the numbers are so incredibly small. Presumably, at least some of the reason that maybe some could develop graft versus host disease is one of minor histocompatibility antigen differences, or the immunologic differences that come from just a different life's experience, even if they're genetically the same. Or I'm not really sure how best to study it in light of the small population, unfortunately. I have to give that some thought.
Animal models.
Yeah, interesting question. We have a question in the chat from Dr. Alawat. How often do you rely on endoscopic biopsies in diagnosing and monitoring GVHD?
So as far as diagnosis is concerned, it depends on the type of GVHD and the pretest probabilities. We tend to biopsy more often than not, we tend to biopsy. If it's some skin GVHD where you could start empiric topical therapy, patient gets better, it's not that severe, it goes away really quickly. By the time you get the patient to biopsy, it may already be gone. But for people who have GI GVHD, especially upper GI or lower GI GVHD, a lot of times you'll start treatment even in the absence of a biopsy. However, I'd caution that a GI biopsy, especially an intestinal biopsy at diagnosis, it does have extremely high yield because it also helps exclude other causes like cytomegalovirus, which you would not be able to identify on a stool study. So, in general, the GI GVHD patients are referred for endoscopy, biopsy, quite often, if not universally, because there are obviously some circumstances where they're too sick to get it or what have you. But we tend to biopsy a fair amount. By the same token, if you have a liver GVHD patient, if you start the patient on steroids, with a high pretest probability, say you've already proven they have GI GVHD, you start them on steroids and their bilirubin is high at the beginning, it goes down, you may not be as quick to refer them for a liver biopsy as if they do not improve, and then you'd get the biopsy. The challenge, though, in terms of serial endoscopies for showing healing is that, it takes a long time sometimes for people to get better. And so for somebody who's clinically improving, I would not push for repeat or serial endoscopies or colonoscopies. For somebody who was improving and they get worse, or somebody who is not responding to treatment as you would expect and the risk is not too high, I think further endoscopic sampling could be and should be considered when possible to exclude a superimposed process, right? So if you've got somebody who's at risk for a CMV infection, you've biopsy proven lower GI GVHD, you start them on treatment, it's always pretty immunosuppressive. They're getting better and then they're not, right? It's possible they now have a superimposed CMV. And so, the clinical circumstances might dictate a repeat sample.
Thank you, Dr. Etra, and I want to thank you again for this really interesting presentation, a complicated but critically important topic, and thank you for all the insights that you've given to us this morning. I want to thank everybody who joined Grand Rounds, and hope you enjoyed it as much as we did, and wish everybody a great rest of the day. Thanks very much.
And thank you again for the invitation.